Hello, everyone. We are hi everyone. We are here today in a committee talking about heart failure readmissions and how we can reduce the factors that contribute to them. We have Brian with us. We have Ishmael.
Hello.
Hi, Ishmael, and we have Lenny. And my name is Tatiana. And we need to come up with a report for our administration as to how we can address these factors. They can be related to nursing and quality of care, the hospital, and obviously the comorbidities that are very individual to each patient. So what do you think? What do we have? Brian?
Oh, okay. Thank you. Sorry, I had to unmute. Well, what I was thinking about is something I found was interesting, trying to figure out where we were going to begin to approach here. And I know a lot of other quality indicators by different agencies, like the Joint Commission. There's a couple other ones that I'm thinking of, but particularly the Joint Commission, there's certain things they try to track and categorize. And the current method, I think, across the board in a lot of situations is that we use billing information. That's why a lot of it has the medical coding, and so we try to use that with if something's qualified as a readmission, it gets flagged in the system. And so I think that's what we're seeing a lot of coming back on right now is that we want to quit that from doing that. So I think what we need to do is maybe not necessarily reinvent the wheel, but see what's out there to approach it a different way. Because there was a recent study by the American College, or by a couple group members from the American College of Surgeons. A little paid research study done by, now I'm gonna butcher these people's names, but Hecken, Bleichner, Macari, Samarov, Bennett, Gerhardt, Efron, and Wick from 2013 in the Journal of American College of Surgeons, talking about how readmission, looking at hospital readmission data, by how they're looking at it, is kind of not as accurate when we use basically what they use is the University Health System Consortium database, which kind of look based on billing code. What they use is another thing they have, because they're currently trying to take control of analyzing certain things they want to improve on, such as just for certain surgical things. So the database they were using was the American College of Surgeons National Surgical Quality Improvement Program, or the ACSN-SQIP. And they were basically using this to compare how does the data gathered from that database compare to the UHC database, the Health System Consortium. And what they found is that trying to track readmissions using administrative data that's used for billing purpose is a horrible way to do it. So what I'm thinking we need to do is similar to the way they used a different program. We need to try to look at specific things for congestive heart failure, and maybe even design our own database or see what things exist out there to allow us to kind of track specifically what things from our chart we're looking at. Because I think just saying that, oh, CHF readmission it looks horrible, but there might be things that are happening outside, or things that are outside of our control, or certain things we could focus on at time of discharge or during the first admission to the hospital that would allow us to kind of keep better track of this. And one thing that I found, based on the AHRQ system that we've kind of been talking about as well, they have a readmission format, a form that we could probably use. They are part of the website I found it on was the PSO Privacy Protection Center. That's through the ARH. Is that right? Yeah, AHRQ. I'm sorry. And I'll do a screen share to show you the little form I think we should kind of base all of our things off of, or at least try to come up with something on our own. So I will show you this here. And if anyone has anything to interject, please let me know. I can't see the screen right now, but so it's from this website right here. Please go ahead.
Just tailing off of that, the AHRQ website also has a user guide for their readmission analysis program, and it talks about exclusions as well. And what the reason I was thinking of that is because what you were saying about flagging patients that come in, and so using what information did you say to flag them, Brian?
Typically, it's based on billing.
Okay.
There's a large third-party de-identifiable that uses the billing code to say this is all our readmissions type deal. Once it's de-identified, they're a data miner, from what I understand.
Oh, okay.
United Healthcare. Let me look at it again. I always these.
So
I
no,
agree.
that works, but we could use the billing, but then the AHRQ has exclusions to that then we can fine-tune the patients from. And then from there, obviously, we need to get more data. But some of the exclusions are readmissions that were scheduled or planned. So in billing, they may be flagged because their name came up to bill them again. But it may be flagged for something that was scheduled, in which case that's not what we're looking for here. We're looking for a readmission because of, a heart failure problem.
Associated problem, exactly.
Right? So they also say readmission of patient with maternal deliveries and all of this stuff, just in case any admission happens from this patient who had heart failure, within 30 days, if they get admitted for something else, like they broke a bone or something,
yeah.
that's not included in the study. So we can use their exclusion criteria as a way to isolate our population.
I think that's a great point. We should definitely write those two things down in terms of the exclusion
I'm on
criteria and using the format.
So billing info and then the AHRQ exclusion criteria. To just narrow it down to our patients, and then we got to talk about like what kind of data that we need to get from you.
Yeah.
Exactly. I think that's kind of what we're looking for today. Is what information are we going to use, and then how are we going to get it? I believe is what we're trying to look at today.
Okay.
If you don't mind, go ahead, Ish.
No, you go ahead, Tatiana. I can add after you.
All right. Well, I guess the article I was looking at by Desai and Stevenson from 2012, Hospitalization for Heart Failure, Predict or Prevent. They were saying that only half of those hospitalizations are happening because of problems related to heart failure. They were saying that's why it's kind of really hard to come up with a model, something that would help us avoid those readmissions, because there are a lot of problems that are very personal, very physiologically individual to people. So there are some things, say as problems such as hypertension, fibrillation, arterial fibrillation, which are the associated diagnoses, and then any kind of renal impairment or worsening. So maybe we can look at comorbidities that the patient initially has.
Mm-hmm.
So that would be, I guess, if we're using EPIC in our hospital, which we are, right? So we could probably go into patient's medical history and determine whether or not they're at high risk.
That sounds good. Actually, I have an article from the Journal of American Association of Nurse Practitioners that talks about patient and process factors associated with all-cause 30-day readmission among patients with heart failure. And they said that renal failure and renal insufficiency was in their study, the only factor significantly associated with all-cause readmission for heart failure. But they said part of what some of the information we need to collect because of that is of patients who appear to be ready for discharge but have creatine levels above their baseline. So monitoring those levels at discharge maybe is something we want. I mean, that's like a specific piece of data, but one of those elements that we want to include in this.
So,
Yeah, absolutely. Probably hormones and biological markers as well.
Mm-hmm.
so based on my research, some things that I've found regarding this topic of how we're going to monitor readmissions. According to a recent report done in 2012 by the AHRQ, Agency of Healthcare Research and Quality, they did a program or a criteria of how to set up a readmission criteria. And one main things they talked about, specific topics that we should look at, was a presence of specific adverse effects. You mentioned, Lonnie, and you mentioned, Brian and Tatiana, that we want to know whether or not it's for renal issues that are coming, or whether or not it's for fracture. We really need to check for the presence of a specific adverse effect and ascertain if that adverse effect relates to heart failure conditions. So if they have a fracture, we wouldn't worry about it. But if they have something like, you'd say, when you check them, you see they have extremely low ejection fraction, lower than 40%, then you know that this is related to heart failure. If you know that they have pedal edema, then you know it's related to heart failure. Then another thing that needs to do, our documentation, our readmission report needs to document specific action that are taken at the beginning of hospitalization all the way till the end of discharge. So this will also identify many other variables. Let's say we're not really certain that the patient was readmitted specifically for heart failure, or certain measures weren't indicated. If we monitor all actions taken, that would help us really see what issues led to this patient being readmitted for heart failure. Then another part is we need to assess the risk factors for readmission, and we need to make sure that those were discussed either with the nurses, with the social worker, whoever is in contact with the patient, that these issues were discussed. So that would also monitor our proactive preventative measures that we are taking as a hospital to prevent readmission. Then we also need to monitor length of stay, so let us know that the window, the timeline in which we have with these patients to find the best time in which we can, address the risk factors for readmission and help these patients prevent further problems, prevent them from being readmitted. So, I mean, those were a few things that were addressed in the common format readmission version 1.0 beta, specific topics that we should look at when creating our readmission report.
Just to support that, Ishmael, Gallagher in 2003, this is kind of silly, guys, but I love the quote. Quality is ballet, not hockey.
It's ballet, not hockey. Wow.
That's what it's saying, right. So in the Gallagher 2003 article, it was talking about quality nursing indicators that can be useful. But it was just like what you were saying, is document all of the care, because what we don't know exactly what would cause readmission of a heart failure patient, right? I mean, that's part of what we're studying. So if we track all of that, then we will begin to collect the data that we need in order to create interventions that will work. But it says quality is ballet, not hockey. Ballet in which all of us must move forward together in claiming the future of nursing through nursing-sensitive quality indicators.
I didn't hear the last part. Could you please repeat that?
Claiming the future of nursing through nursing-sensitive quality indicators. And it says that it's up to patients, families, professional nurses, nursing administrators, and all who have interest in provision and receipt of quality care.
Excellent.
Yeah.
Yeah.
LA.
You know, if you don't mind, just kind of all you were saying made me think of actually both articles by Peterson from 2012 and Gallagher, the one you um, just referenced. So it's not just the comorbidities, it's the quality of care, right? So both of them talk about patient safety being the fundamental goal. So it's not only how we're providing that care, but also if we provide teaching, if we provide education, so the patients are able to take care of themselves once they transition. And there are those three phases. First is the transition from the hospital, then it's actually taking care of themselves while they're home after those first very important critical 30 days. And then the third one is when they actually need the palliative care or something. But I guess yeah, sorry, kind of lost my train of thought there. But the safety of the patients and the quality of the care, we can actually do it. So like Lani said, we're not sure what it is that is going to cause it for sure, but if we try to come up with close to an ideal standard of
And
things that we can
yeah.
do, and we can tell them that they can be up to par with, maybe we're going to be able to reduce the returns.
What were you
I
saying?
absolutely agree with you.
What were you saying those three things were? I mean, it was transition, and then palliative.
So this is from the article I mentioned from the American Heart Association. It's called Rehospitalization for Heart Failure, Predict or Prevent. So they're talking about the three phases. Yeah, so the first one is transition from hospital to home. These are the first 30 days, and even though they vary 10 to 50% as across the United States as to how many readmissions there are, they're saying that 75% can actually be preventable in
Huh?
that phase.
In the first
So
30. Okay.
first 30 days. So essentially, this is the highest risk, but 75% of that can be prevented if we are prepared for it, obviously. Then the second one is called the plateau phase, and this is it is less the transition, but it's still relatively high, and that's when we need to make sure that we educate the patients. We need to tell them where the clinics are so they're able to address their signs and symptoms at a timely fashion. And then the third phase is called palliation and priorities, where we provide palliative care to the patient, and they're actually saying that the introduction of palliative care seemed to be helpful in prevention of those last days readmissions for heart failure.
Hi, sorry, I don't know what happened.
Were you able to hear me?
I might have
I heard you.
last bit.
Okay. Well, let me know if you need me to repeat any of that.
Okay.
I think, I mean, those three things that you mentioned are really key points that we also need to jot down. Are we jotting things down, Lonnie,
Yes.
in the board? Yeah. So, I mean, you could just list them really quick for Lonnie to jot down, Tatiana, so we keep them like the plateau phase, what's the other two phases?
The three phases are transition from the hospital to home, plateau, and palliation and priorities.
And we know that we have to target them highly in the transition phase because that's the place where 75% readmission occur. Okay, okay. And go ahead, Lonnie.
Oh, I said I got that. Thank you.
Oh, wonderful.
And I was actually, if I could, because there was this study of interventions for heart failure readmission, successes and failures. And it goes through a bunch of stuff, a lot of things that did not work, different programs that were used. But what they did find, and it kind of correlates with what Tatiana was saying, that did work was, here we go, the various interventions. Okay, various interventions exist to reduce readmissions. The best were those that targeted the transitional period and used nurses or dedicated coaches at each point of patient care team interaction, as well as prompt and meticulous follow-up, both in person and over the telephone. So those had the best results so far.
Meticulous telephone calls, prompts. What was the other two?
Prompt follow-up.
Yeah. So
Yeah.
those should be bulleted too, I think.
Yeah.
Brian, did you have something to say?
I did. I just wanted to dovetail onto the end of that there because I also was looking at something that kind of, the paper kind of goes against what I was thinking, but it did have an interesting point. It's by Keenan, Norman, Lynn, Dry, Batt, Ross, Crumholz from a 2008 magazine, Cardiovascular Quality, Circulation, Cardiovascular Quality and Outcomes, where they were talking about, I want to go even a step prior to the proper transition, like the transition phase, because they mentioned the transition phase, but they also mentioned the idea of the readiness for discharge, which I don't know if that's something we could come up with, where it's say, hey, this patient, the education is met, because the other thing, the readiness, I don't think we've addressed at any point in time, because sometimes it's just, we need the bed close enough, let's get them out of here, and then who knows, we don't have, if that's the case and we don't have the documentation that they are ready for discharge, we're setting them back up for to come back in 24 hours because they don't feel comfortable with it. And so what I'm thinking is, as we're designing this, is we kind of take, that's actually one of the top things for Joint Commission's heart failure core measure set, is one of the major things they have is discharge instructions. There's three. That's the discharge instructions, evaluation of left ventricular systolic function, and then an ACE inhibitor or ARB for the left ventricular systolic dysfunction. I think that's how it's.
Oh, I have that too, yeah.
So those are the things the Joint Commission recommends, which I think that when those three things are met and the education is the most proper thing, that then we can move on into the transition to the transition phase. But I think if we're going to kind of design what I think our readiness factors readiness for discharge have to be considered as well. And maybe we can build off of that.
I think that's a beautiful point.
That's a great idea, Brian.
I don't know if you got, oh, sorry, go ahead, Ish.
Okay, thank you, Lonnie.
Mm-hmm.
If someone, I know I shared with you guys a PowerPoint with the slides. If someone could screen share it, I would like to discuss. I mean, you mentioned basically exactly those core measures, and just to show us how these assessment of these core measures can help us as a hospital once we decide to monitor readmission. You know, the few hospitals here in Tucson, according to a recent report from Medicare.gov titled Medical Hospital Compare Quality of Care, this report was done in 2004, assessing CHF care from 2002 to 2013. They showed that at TMC, the specific topic that you were talking about, Brian, giving heart failure discharge instruction and teaching, TMC Hospital provided that teaching to 100% of the patients, so it shows that TMC is doing a good job. UMC provided 90%.
Is this what you want up, Ish?
Yes, this is what I want to go. You're doing awesome, Brian. Keep going down. It's slide 13. Keep going down.
Slide 13. There we are, right there.
You're amazing. Exactly. If you can see in this slide, you know, the two main hospitals here in Tucson are doing really well on heart failure teaching, providing evaluation of left ventricular systolic function. They're also providing ACE and ARBs. But other measures at the bottom there in the low 90s, which is flu vaccination and pneumonia vaccination. And so My point in bringing this chart up was just to so that agreeing with you, a comment you made earlier, Brian, that we don't really have to reinvent the wheel. The Medicare already has a system where we can add whatever we include in our readmission assessment program. We can add it to what's currently being run by other hospitals, and then this information would be shared and allow us to compare how we are performing in comparison to the other hospital. A last key point, a benefit that I'm sure you guys are all well aware of. According to a report, where was this report obtained? Oh, it was actually also from the AHRQ 2012 report. It's really important for us to do this because the Affordable Care Act, they're pushing also for us for being reimbursed by showing that we are taking, how do I say this? By creating a chart like what I show you guys, this allows us to show to comply with Affordable Care Act, so that in case our hospital is in trouble for not getting funded, we can say, okay, in comparison to other hospitals within our district, we're performing. This is our performance, and we're exceeding national standards, or we're meeting state standards and such. So it's also, we also got to consider how we're going to get funded to continue to provide CHF care.
That makes sense. And there's core measures, like you were saying, too, already in existence.
Yeah.
That are there that we can use.
Exactly.
Yeah.
Go ahead.
Oh, I was just going to expand on, I think it was Brian that mentioned it, and Ish as well. The NCQA website also put down things like flu shots, which was shown on Ish's PowerPoint, was something that we need to track and assess. And then the medications, like Brian said, but also the length of time that they're on medications, they said was important to follow as well.
Yeah.
And the type of heart failure?
Yeah, good point. I think that was also there, whether it's left heart or right heart failure.
So what I'm wondering, if maybe just to kind of be moderator here, because we're kind of hitting our 30-minute mark, I'm wondering if maybe we should start kind of thinking of what we want to put in our readmission tracking data form, and how we're going to do that. Are we going to use the AHRQ form as a basis? Are we just going to use that as is? Or what would we like to do? What are the things you guys want to try to think about with this?
Brian, I liked your idea with the form, and I think you mentioned talking to the IT department as to possibly making it into a program. Did you mention something like that?
Yes, I did. I think we might have mentioned it when we were passing in the hallway of this fine establishment we work in here. The one thing I kind of wanted to, the reason I was thinking about that is that article by, oh God, I hate this last name, Heckenbleichner from 2013 in that Journal of American College of Surgeons. The one thing they mentioned that was better about their using their system is that there were nurses or clinically trained staff who were entering the data versus just a billing specialist who's transferring it on. So I think that we'll have to have some sort of implementation program where we sit down and on our floor we have maybe it be whether, I don't know whether unit by unit, we have a quality assurance representative or quality assurance nurse. I know some hospitals I've worked with have somebody who sits in an office and does data analysis and pulls things for charts, looks for every time there's a CHF to the floor, looks through the past history and try to figure out stuff. Well, this should fall onto them to where they're looking through and pulling stuff and saying, was this done before? And here's this one that's a readmission, and we send that form in. I think that has if we do that, it's already been proven that should help us track where we need to fix ourselves at. I think everyone's following it, kind of rambling here. So.
Yeah, you know what? Actually, that kind of makes me think of the Gallagher article. They're talking about collecting the data specifically from different levels, so different units of the hospital. So it is just closer to the real deal, like not just spread all over just random information. But if it is a particular hospital unit, we're getting, well, I guess, better information. And also they mention sharing experiences and having more meetings and seminars so we can share those experiences and change and improve. So maybe that's something that we can also implement. Once we've collected that data, we need to share with others, less fortunate units or less fortunate hospitals who don't have these amazing committees like ours, right?
I remember, I think it was yesterday, we were walking in the hall and you were mentioning to me, Tatiana, about, I think, acute care indicators that we could, that we could have Brian also include in the form. What were some of the acute care indicators that do you remember them?
You know what? Let me see. I think I had them somewhere.
Oh,
So,
great.
yeah, so we're talking about the maintenance of skin integrity, the nurse staff satisfaction, nosocomial infections, education received, which we already talked about, the pain management, patient fall rates, nursing care hours per patient per day, and just nursing staffing. And I believe you were saying that they belong to indicator categories. What were those?
Yeah, I agree with you. And I think we read the same article. Is that the article from Gallagher and Rowell?
Yeah, claiming
Yeah, yeah,
nursing sensitive
exactly.
quality indicators. Yeah.
Exactly, nursing administration quality. The non-acute care indicators that I found that I was talking to you about, where it's really important for us to acknowledge the symptom severity that the patient, like how severe the heart failure is. Is it their ejection fraction 20% versus 40%? The therapeutic alliance, how the entire healthcare team, given it from the physicians, the nurses, respiratory therapists, the whole therapeutic alliance working, do we have a measure to see how all the system is interacting? I mean, all the healthcare professionals are interacting to address the healthcare. We need to also assess use of. Oh, sorry. I think I made a hiccup. What I'm talking about, I need to specify. This is non-acute care indicator, community-based non-acute care indicators, guys. And there's 6 things that we need to include. This would be something that we would assess for patient maybe when they're following up with their physician. This is not something that we'll look at while they're in the hospital. And the 6 things that we need to look at is we need to see what is their symptom severity, how severe is their heart failure, what is the therapeutic alliance, are they using the services that were prescribed for them, once they were discharged, are they filling their prescriptions, are they going to physical therapy, are they following diet, which is also big in CHF management, fluid restriction and things like that. What is their level of function? That also needs to be included in this report. And also patient safety. That's a big factor, especially CHF, considering it affects a significant amount of older adults. Are we considering patient safety factors? Because this is going to minimize them being readmitted. So while Brian has provided an excellent report for the hospital, it's important also to add to this report for the community-based non-acute care. Go ahead.
Yeah, it also kind of goes along with what you're saying. We also probably need to consider the socio-economic status and also any psychosocial problems that the patient might have, because that would probably reflect in their medication compliance, follow-ups, any other adherence. to the things that they need to be doing to keep themselves safe and away from the hospital.
Exactly. So maybe, Lonnie, we could include those two things in our bullet in addition to Brian's beautiful template that we would use for our readmission criteria. So we have the acute care indicators and we have the non-acute care indicators. We don't need to list them all for the purposes of time.
Okay.
I think we're doing pretty good. Any other?
Right. So, Lani, would you mind telling us what you have down there?
Yeah. I can screen share it.
That's perfect.
If Tatiana, if you just click on her screen on the bottom there, it'll stay on hers if you're recording from you.
I can do that.
Yeah, and so if you click on it, it should keep her screen up, I believe. I think we're recording on your version.
There you go.
And it's, oh.
Wonderful! Oh, then I think I talked. I shouldn't have talked, huh? I saw it just now.
I think you're great. I think we're seeing what Lani has down for us, and go ahead, Lani.
Oh, I was just going to add a little bit about any kind of technology or IT infrastructure that we may need to consider when we're implementing this, as far as, because we have Epic, we have most of what we need. A lot of the software that's used for the data collection can be consulted out, and they can be web-based. As long as we extract the information from the Epic system in a format that's easily readable, what's important is that we have the different criteria and make sure we have all the information. So we may want to work with someone from Epic to make sure that we can access and easily pull out some of that data. And I'm not sure if Epic does anything with billing, so we may need to coordinate with that to, flag certain patients and see how that goes. I'm not sure who does the billing portion for the hospital.
Okay.
No, I'd like to see if we could add just a couple more things for that info to track.
Mm-hmm.
What I would like to, based on the research that Ish has done already with some of the Joint Commission, especially with what we found on the Joint Commission core measures, I didn't see if is there anything about discharge instructions on that.
Oh, I think that was the one who.
I think we need, just as far as what we're going to be tracking for it, and somehow in this template that who's ever doing our chart audits is going to be going through looking for this. I want to make sure that looking at discharges, that discharge instructions were given, that there was an evaluation of LVS function, because we already put the ACE and ARBs on there. Make that two separate bullets, if you could, please. And then on top of it, too, I know, and for the love of me, I can't remember which paper I was reading it in. Maybe one of you can remember for me, or maybe this was just something I just blah.
It's all under discharge, Brian. If so, I'll do this just because I think that's a whole separate thing, and that it is important because it involves education and everything, right? Along the lines of what.
Yeah.
Yeah.
And then also the ACE and ARBs are in there as well, because those are the three core Joint Commission recommendations, and I think that's the NDNQI also focuses on that. I'm not 100% sure though.
NDNQI. Oh.
I think. Look that up real quick while you're typing. And then the other thing is too is that I know, and I can't remember what I read this in, but outside follow-up with whether one of our case managers or basically whoever is falling over with them, at least one contact, and maybe even look at if we may have to implement a protocol having them set up a follow-up appointment with their primary care physician after, or basically set it up for them while they're in the hospital. So not only do we're looking at the fact that we're getting them ready that's the transition period, and make sure they're ready. Because the discharge, I think that's like we talked about before, is are they even ready for discharge? That was that one
Yeah.
article by, those other guys, Keenan et al. From 2008, that are they even ready? And I think this all falls in this readiness of discharge that we'll look through, because that's where if we're not ready to discharge, that's why they're coming back to us so quick.
Yeah.
The instructions given, evaluation, medication, follow-up care, and then maybe a follow-up phone contact like a week after or something like that underneath the follow-up care.
That would be a good one.
What did you want me to add?
With the discharge thing, or even it can be part of that bullet point, or maybe it could be different. Make it so that it says caseworker or case manager phone contact a week
Okay.
after something. Basically, see what's going on. Are you having trouble with your regimen or your stuff like that? This may have to be completely reevaluate our care too, because we may have to have new forms go through IT or our Epic people, have them redesign the discharge form, because if we're specifically looking at CHF, maybe we need a new CHF discharge form, so we can look at this and see what happens, make it easier to pull that information when we run reports at the end of the month or end of the week or end of the day.
Am I missing? Did I get it? Can you see it?
Yeah.
I think you did. I think it looks great.
Yeah.
So I just want to, let's see, go ahead, Dish, I'm sorry, I'm thinking out loud.
No, nothing. I was just adding to Lonnie that I emailed her the non-acute care setting indicator so she can add it later on.
Oh, okay. Thank you.
Yeah, I send it to your email. You could just add it underneath. I think we're pretty good from my perspective.
All right. Would you like me to switch to Lani's face?
Oh.
Or are you still reading?
I'm liking this view, but okay. How do I switch back?
All right. Did it switch? Oh, there you are. Gorgeous. All right. Well, we're going to be able to submit this report to the administration. Is there anything else that you might have missed and somebody wanted to add?
Brian, yeah.
I just wanted to make sure before we all leave that that I agree with you, Tatiana, that we're at a point where we can we've met our things, but I just want to, as what the administration gave us, to make sure we feel that we all met this. So do we feel that we have figured out what needs to be in this report, right? We've done that.
Yeah.
And we think that, I mean, most of the stuff we're coming from is the joint commissions where we found the 3 of them, and we're building off the top of them.
Mm-hmm.
That's the other things. That's the internet site we found on them, and that we are going to use Epic to basically, what's the word I'm looking for?
Filter out the information that we need.
Yeah, it starts with a C, but I can't remember what it is.
To compile.
Yeah, that's the word. Attaboy, compile. That's right. Compile your data. That's right. Okay, so we feel that we're going to do that.
Billing in that as well. Yeah.
We're going to put that as well, and we'll probably have our quality assurance person per floor or whatever. I'm assuming we have. I think I've seen them locked away in little offices here and there. So that could be part of their thing while we're doing this research. And I think the infrastructure we're going to use is basically what's already on Epic. We may need to talk to the Epic designers to see if they can have an actual report or form that we're using that'll make it easier to run that on. We may also need to see if there's a certain database that allows us to, whether it be just as simple as a Microsoft database, where we're keeping track of that information that's de-identified and allows us to track what's going on. Or maybe there's something in Epic that I don't even know about, but they may be able to do that for us. So I think that's the main things that administration charged us with, so I think...
Most databases.
They do? Okay.
Good. Even Excel can do it.
I'm relying on you, Lonnie, since you're our tech girl.
Tab delimited is all that matters.
Wonderful.
All right, sounds great. Thank you so much for being here, guys.
Thank you.
Very helpful.
Perfect. All right. Well, we'll maybe back later and see what they think of our work.
Okay, sounds good.
Great job, guys.
All right.